For those of you who don't know me, I'm Donna McKay, the Executive Director of Physicians for Human Rights, PHR. I just want to thank you for taking the time to join this discussion today on the implications of COVID-19 pandemic for people experiencing homelessness and unstable housing situations. I'm told that we have over 500 people registered for today's discussion, and this is the 10th in a series of webinars that PHR has put on. And it just says to us that clearly there's a real hunger for information from a trusted source and also really concrete ideas of what can be done, which is what you'll hear today. Many of you on this call are frontline health professionals that are literally working to beat back the pandemic, as well as many others who are also advocates, working aggressively to address the numerous inequalities that are further revealed by this pandemic. The right to housing is recognized in a number of international human rights instruments, including Article 25 of the Universal Declaration of Human Rights, which states that everyone has the right to a standard of living adequate for the health and well-being of himself and his family, including food, clothing, housing, and medical care, and necessary social services. And yet more than 500,000 people living in the United States are experiencing homelessness. Every one of them is at a dramatically increased risk for this pandemic. They're more likely to catch the virus, more likely to experience complications, and they're more likely to die from it. And already economically disadvantaged, those without reliant housing are suffering further from the nationwide economic fallout, which has been brought on by the pandemic, including some of our essential workers. So today we have the pleasure of benefiting from medical and public health experts and advocates who've devoted their careers and research to ensuring the right to housing is recognized as a universal human right. Their work, as you will hear, and their insights have become critical at this juncture, and we're really looking forward to hearing from them. We welcome your questions throughout the briefing today. You can send your questions to webinar@phr.org, or you can just submit them right to the Q&A box here, and we'll do our best to address them later on in the session. So I'd like to introduce you to our moderator. I'm thrilled to, PHR's Medical Director and Board Member Emeritus, Michele Heisler, a Professor of Internal Medicine and Public Health at the University of Michigan. Dr. Heisler has long been affiliated with PHR in her work, having participated in multiple field investigations and co-authored PHR reports since she was a medical student in the mid-1990s. Dr. Heisler's research has uniquely focused on applying health services research approaches to advance health equity and human rights among vulnerable populations. Throughout her career, she spearheaded the development of methods, programs, and evaluation tools aimed at improving health through promoting individual human rights and activating low-income individuals to effectively manage their health and healthcare. So I'd like to turn it over to you now, Dr. Heisler, to introduce our panelists and get us started. I'm going to take myself off the Zoom and return at the end.
Thank you, Donna. Welcome to all of you, and thank you for joining us today. Long before this pandemic, homelessness has been well established as one of the most powerful risk factors for ill health, disability, and premature death. In turn, ill health and disability are risk factors for homelessness. As Donna mentioned, having a stable home is one of the most fundamental social determinants of health, and the right to live somewhere in security, peace, and dignity is considered a basic human right. The reasons people do not have access to stable housing intersect with multiple structural inequities and human rights violations. Discrimination and racism lead to far higher numbers of homeless people of color. Mass incarceration and poor provision for decarcerated individuals lead to high rates of homelessness among people released from jails and prisons. Lack of legal protections and enforcement leads to evictions. Pandemics and other disasters clearly demonstrate what Paul Farmer has called the biological reflections of social fault lines. They both heighten and make more visible the hardship that many people experience long before the crisis. And COVID-19 has indeed been a great magnifier of disparities and systemic inequities. Crises like the current pandemic also reveal how close many people live to economic disaster that then leads to homelessness. Globally, as many as 2 billion people lack adequate housing. We're focusing on the US today, and millions in the US live on the brink of losing their homes. Los Angeles County alone has almost 1 million residents living in households that are one paycheck away from being unable to cover their rent. Across the US, 8 million households pay at least half of their income toward housing, putting them at high risk of homelessness. Just this past week, as we were planning this session, I learned during my clinic at the Ann Arbor VA that one of my longest standings and most cherished patients had recently become homeless. He depended on income as a taxi driver. That had dried up these past months, and he was left unable to pay his rent. He's now living out of his car. My patient, like many, like most of us, are proud people. He's a proud person who does not like to reveal any hardships he's facing. In fact, he only revealed his homelessness to me inadvertently because he vented to me about his frustration that the VA, under the new COVID-19 restrictions, would not allow him in to use our showers. He could sleep in his car, but he had no place to shower. I was able to link him to housing resources, including the option of a single room where he can socially distance. But I was well aware that many of the services I was able to link him to are only available for veterans in the VA system, not to millions of others facing homelessness. So for the sake of this patient, for those who are chronically homeless, for those who will become homeless over this pandemic, and for those of us who care about the kind of society we live in, I am so grateful for these 3 experts to join us today. Together, they'll elucidate key features of the problem of homelessness, key challenges and some solutions during this current pandemic, and how things might be different going forward. Each of our speakers will make brief opening remarks, and I'll then start off with a few questions. And then please, all of you out there, wherever you are, we will be taking audience questions. So please send us your questions. The first expert joining us today is Pascal Leon. She's the Director of Diversity, Equity, and Inclusion at the Corporation for Supportive Housing, CSH. She has deep expertise in public health initiatives that reduce and prevent racial, ethnic, and gender-based health disparities. She brings more than 15 years of experience promoting a diverse and inclusive work environment and equitable outcomes at CSH. Prior to joining CSH, she worked and held appointments at the American Lung Association, Black Women's Health Imperative, and Planned Parenthood Federation of America. So thank you so much for joining us, and I will now turn it to her.
Thank you so much, Michelle. And thank you, Donna, Michelle, and the Physicians for Human Rights, and for that important grounding for today's conversation. I also want to extend my profound gratitude for the opportunity to be in community with all of you today and to sit on such an esteemed panel with women I admire and value deeply on this important topic. As Michelle had mentioned, I am Pascal Leon. I serve as the Director of Diversity, Equity, and Inclusion at CSH out of our New York office. And for those who are unfamiliar with CSH, very quickly, we're a national nonprofit dedicated to using housing solutions to improve the lives of the most impacted and historically marginalized neighbors. We work with communities to help transform systems, to maximize public resources, and to build healthy and resilient communities. As you've been watching week by week, COVID has proven to be an issue of inequity, really caught at the intersections of pre-existing vulnerability and social marginalization. It has made visible the invisible people in places we as a nation have collectively ignored or systematically silenced. Jails, prisons, nursing homes, and shelters, for example. And this pandemic has also exposed this nation's long-standing racial and ethnic disparities that have been made apparent with the disproportionate rate of COVID cases and deaths experienced in predominantly Indigenous, Black, Brown, and low-income communities. And so today, my colleagues and I will attempt to unpack a lot of this, these inequities, with a particular focus on those individuals experiencing homelessness and housing instability. But first, for those who may not be familiar with supportive housing is a proven evidence-based intervention that combines affordable housing, where a person pays no more than 30% of their income towards rent, by way usually of a subsidy, combined with critical community-based wraparound supports and services such as mental health services, substance use treatment, intensive case management, and vocational services that really create opportunity for recovery, personal growth, and lifelong success. And so at CSH, we say that supportive housing is really for folks who, without these services, cannot maintain long-term housing stability, and without housing, really cannot engage in these critical and important services. So the two are really codependent and thoroughly linked. So supportive housing has proven to help people who face some of the most complex challenges, including institutional cycling and experiencing homelessness and chronic homelessness. To help ground today's conversation, I was asked to kind of open up with some stats and what we know about people experiencing homelessness and those unstably housed. Nationally, there are over 560,000 people experiencing homelessness in the US. About 2/3 of those individuals and families are in emergency shelters or transitional housing programs, and more than 1/3 are living on the street. There are about 172,000 people and families with children experiencing homelessness. And you may have heard of the term chronically homeless, and that refers to an individual or head of household with a disability, so like either serious mental illness or substance use disorder, who has been continuously homeless for at least 1 year or experienced 4 episodes of homelessness over the course of 3 years for a combined total of 12 months. There are over 96,000 people experiencing chronic homelessness in the United States. And people of color continue to make up a disproportionate share of the homeless population. In particular, African Americans account for 40% of all people experiencing homelessness and more than half of families experiencing homelessness, despite accounting for just 13% of the US population. And when it comes to disability, based on conservative estimates, there's about 30% of people experiencing homelessness that have a serious mental illness, as compared to about 6% of the general population. In addition, folks experiencing homelessness are roughly 2 to 5 times more likely to have a substance use disorder than the general population. And so pathways to homelessness, vary greatly and do not take one singular form. The example that Michele provided about her patient is one that we see right every single day. One can connect the spike in modern day homelessness to the role that deinstitutionalization in the late 1960s and 70s played without the proper investment in community-based supports and services and affordable housing, quality and accessible housing, and the lack of healthcare coverage and access, that revolving door of institutional cycling, individuals escaping domestic violence, and the result of structural and institutional racism, to be clear. And lastly, another group that we want to focus on for today's discussion are the housing unstable and those at risk of homelessness. And so before this crisis, we had a housing crisis, and one that COVID will undoubtedly make worse. Over 1/3 of American households, both renters and homeowners, are considered housing cost burden, meaning that they spend more than 30% of their income on housing costs. And those who are severely cost burdened, those who spend more than 50% of their income, account for about 15% of American households. And so similar to what we're seeing in the homeless population, there's also an overrepresentation of Black and brown families, accounting for a disproportionate share of extremely low income renter households. And so, there's a lot to unpack, and I look forward to discussing these data and more with the panel. And as CSH's board member, Roland Lamb, says, he describes the lack of housing as being a social determinant of illness long before we learned that was a social determinant of health. And so I look forward to discussing more with you all. Thank you.
Thank you very much. Thank you, Pascal. So our next speaker, who we'll turn to next, is Dr. Kelly Doran. Kelly is an assistant professor in the departments of emergency medicine and population health at NYU School of Medicine. She is a practicing emergency physician in New York City. She's been involved in homelessness-related work for the past 20 years. She served as a senior advisor in New York State on an initiative that I hope we'll hear more about, that to use Medicaid to fund supportive housing, that Medicaid dollars should consider housing as healthcare and fund it. She's been an invited panelist at the National Academies of Science on the topic of social determinants of health, like housing. Her current research spans topics at the intersection of homelessness and health. And she's widely published. Some of her recent studies have been published in Health Affairs, the American Journal of Public Health, among others. So thank you, Kelly. So we turn to you.
Thank you, Michelle. And I'm so pleased to be part of this panel today, and especially for this audience, Physicians for Human Rights, because housing is a fundamental human right. COVID-19 has shown us just how incompatible homelessness is with health. And even before COVID-19 started, we knew that homelessness was associated with poor health. There have been years and years of studies showing us that people most commonly think about substance use and mental illness when they think about people experiencing homelessness. And these are important for a minority of the people experiencing homelessness in the US, but also people experiencing homelessness have above average rates of basically every chronic disease across the board when you look at it, including many of the same chronic diseases that we know put people at high risk for poor outcomes from COVID-19. Diseases like uncontrolled diabetes, uncontrolled hypertension, chronic lung disease, and obesity. We know even before COVID-19 that homelessness is associated with higher mortality rates and with premature mortality, with people who are experiencing chronic homelessness dying on average 20 years earlier than people who aren't homeless. We also know from research conducted actually by Dr. Kushel and others that people who are homeless essentially have premature aging. So in their 50s, they have rates of what we call geriatric syndromes, things like urinary incontinence, falls, dementia. They have rates of those more similar to what we see among people who aren't homeless in their 70s or 80s. And we also know from research that I've been a part of with Dennis Pullane and others that homelessness in the US is aging. We have more and more older people who are homeless in the US. In 2017, in New York City alone, we had over 10,000 homeless adults aged 55 and older who used a shelter in that year, with more than 2,500 of them being over the age of 65. And now in my emergency department in Manhattan, it's not uncommon that I'm seeing patients who are homeless and in their 70s and their 80s. And all of these factors, the aging, chronic illness, all of these, they put people who are homeless at high risk for having bad outcomes and even dying from COVID-19. Simultaneously, people experiencing homelessness are at high risk for contracting coronavirus. Those who are unsheltered, so people living on the streets or in encampments, often have poor access to hygiene resources, which makes it harder for them, for example, to follow guidance around frequent hand washing. People in homeless shelters face a different set of concerns. Homeless shelters, like nursing homes and jails, are congregate settings generally, and so people living in them face a lot of the same challenges that we see in other congregate settings like jails and like nursing homes. People are sharing sleeping spaces, they're sharing meal spaces, they're sharing bathrooms. So, while there have been guidance from the CDC and from local health departments around what can shelters do to try to maximize social distancing, to try to minimize spread of infection, it's really hard to do in that type of setting. Some of the shelters have attempted to do temperature checks or screening for symptoms before people are coming into the shelters, but we know that that misses a lot of people. So in studies that have done universal testing in homeless shelters, they have found high rates in shelters, even once you get a cluster of 2 or more people who are known to have COVID. When they do universal testing at those shelters, they find high rates of positive tests. For example, there was a study done by Travis Baggett and his colleagues, published in JAMA, that found that when they tested a shelter where there was an identified cluster of COVID-19, 36% of the residents tested positive, and the vast majority of them were asymptomatic. Unfortunately, we've seen indication that these are not just abstract concerns. In New York City, which is the epicenter of the pandemic, as you all know, we've seen that people experiencing homelessness have been gravely affected by COVID-19. We are not doing widespread or universal testing yet in our shelters in New York City, but even still, we know that there have been more than 900 people who are homeless in New York City who have had positive COVID tests. Across 170 different shelters, more than 170 different shelters in New York City. And sadly, we also know that there have been 75 deaths so far among people experiencing homelessness in New York City due to COVID-19. I'll just end by saying that to have such a large group of people at higher risk of both contracting and dying from COVID-19 is an unacceptable health crisis and an unacceptable human rights crisis. And I look forward to our conversation today about how we can address these crises. Thank you.
Thank you, Kelly. And then our third speaker is Margaux Kuchel. Margaux is a professor of medicine at the University of California, San Francisco. She's director of both the UCSF Center for Vulnerable Populations and the UCSF Benioff Homelessness and Housing Initiative. She's a practicing general internist at the Zuckerberg San Francisco General Hospital. Her research is centered around the causes and consequences of homelessness and housing instability, with the goal of preventing and ending homelessness and reducing the effects of homelessness on health. So thank you, Margaux, please.
Thank you, and thank everyone for joining us. And it's great to be on this panel with two of my favorite people, Kelly Doran and Pascal Leon. I'm going to actually address my remarks for what localities, states, the country has done in the setting of this crisis, which I like to call a crisis upon a crisis. The homelessness crisis has been with us now for about 40 years, and then you throw in a highly infectious, highly morbid pandemic, and you really have the makings of a catastrophe. I think faced with these dual crises and driven by the recognition that, that we need to slow the spread of this disease to save lives across the board, and frankly, by the recognition that our healthcare systems, are really at risk of being overwhelmed. I wish I could say that all of this response to homelessness was centered on the needs of people experiencing homelessness, but I think we need to be real now and say that some of the motivation for the responses has actually been the recognition of the community toll and the toll on the healthcare system. There have been, in some places, some responses. These responses really fall into two general categories. The first one is to try to quickly protect the people most at risk of severe consequences. So with the recognition that everyone experiencing homelessness is at extremely high risk for acquiring the infection, as Kelly said, due to the crowded conditions in shelters in San Francisco, our outbreak, 67% of people in the shelter after 2 initial cases were found to be positive, and also in unsheltered environments. But there was also a concern that certain people would be more at risk for severe consequences, hospitalization, intensive care use, or death. And so there have been efforts to protect those at highest risk, who tend to be people who are older or people with underlying conditions. And this response has been to use recently emptied facilities, mainly hotels, because the travel industry basically collapsed, and in some places dorms, to offer temporary housing so that people could shelter in place with their own bathroom, which is so key, their own private room in their own bathroom, to people who were older or had medical vulnerabilities. I would say this model was best done nationally in Connecticut, which very quickly moved almost everyone from their shelter system, and they don't have very many unsheltered folks, into the hotels. And then in California, where we set up something called Project Room Key, which was meant to target people who were 60 and older, or who were younger than 60 and had medical vulnerabilities. Of note, California first, and then many other states have been able to negotiate with FEMA so that for people who meet these criteria, most of the cost should be reimbursed. As you can imagine, this was a massive effort. It involves usually government bodies. In California, it's mostly been counties to negotiate with the hotels, to basically lease the hotels, as well as some of the staff from the hotel for cleaning, laundry, those type of things, in some places food. They then contract with community-based organizations with expertise in homelessness to provide some of the services to meet the needs of this population. You can imagine this is even harder than housing, because people need to go in quickly, actually don't have a kitchen and basically aren't really supposed to leave their house. We're all sort of struggling with sheltering in place, as well as with healthcare agencies, safety net health providers, public health departments to provide medical support, because you're taking people who are quite medically vulnerable and putting them in place. This effort in Connecticut went very quickly. I would say internationally, London actually did this very effectively. California, we have this program. It has not had the reach we would like it to reach, but it is happening much faster than we've ever done in LA, San Francisco, Alameda County, many parts of California. The next set of interventions were to be able to manage people who were either infected and didn't require hospitalization, or who needed to be in quarantine because they were exposed and therefore at risk of quickly acquiring the infection. These are really been two separate models. And again, this is partially to keep people out of the hospital who wouldn't otherwise need to be there because our hospitals are under such stress. These models in some ways were based on a long-standing model in homeless healthcare called medical respite, which is a way to provide care for people who are basically too ill to be homeless, but not sick enough to require hospitalization. The two main models for this type of care were what we call alternative care sites. These were things like in Boston, eventually it was a convention center. In Seattle, they rented warehouses. New Haven has a small respite program in a high school gym that have some light medical support for people who otherwise wouldn't need to be hospitalized, but who do have infections. These have had some really creative things like telehealth for behavioral health in some of the sites so that the behavioral healthcare providers did not need to don PPE and keep themselves protected. They have a variety of levels of medical support. Most are providing things like opioid replacement therapy, etc. The other model, which has also been tried in many places, San Francisco, LA, actually, frankly, throughout California, and a few other cities across the country, are again using hotels, but instead of this preventive mechanism, they're using it for what we call isolation and quarantine, either for people who are infected for isolation or people who were exposed and at high risk of developing in question for quarantine. This is a similar model to the hotels I talked about earlier. They tend to have a little more aggressive medical support because people are infected and sort of need daily check-ins to make sure that they don't need transition to other places. These are also FEMA reimbursable. They generally have had the same model of joint programs of counties, CBOs, and health departments or healthcare providers, but a little bit more of health. I think that that one of the things that we've seen come out of this is some really novel acceleration of things. For instance, alcohol management. If you take people who are heavy alcohol drinkers and you put them into a place and you don't give them access to alcohol, they're at risk of withdrawal. And so, for instance, throughout California, we finally have been able to do alcohol management where we actually give people alcohol, just enough alcohol to keep them from being in withdrawal. Separate from those efforts, there's been some mitigation efforts, things like the CDC said early on, no sweeps, so that you don't move homeless people who are outside from one place to another and thus take people who may be infected and mix them with people who otherwise weren't infected. This has been variably enforced. Food, because of the collapse of many of the feeding programs, because of a lot of the programs have had to shut down because they can't have everyone clustered together. And so there have been efforts to deliver food to both shelters and encampments, hand hygiene and bathrooms set up to try to increase hygiene. And then there have been a variety of, I would say much later to the game, testing, where we're just starting to build up testing, which has to be a key component of this. I think there have been some real lessons learned. We have learned that we can move people quickly. In some ways, we've always known that. We've had some good collaborations between these different groups that have always needed to work together. And we've been able to stretch what we've done before: telehealth, rapid opioid replacement, harm reduction with alcohol management, etc. These have been good lessons learned. I think that there is now a big effort for people in these hotels to try to transition them to permanent housing, because it would be really terrible if at the end of this, we return people from hotels back to the streets. With the CARES Act, or the third stimulus bill, there was a lot of funding for ESG, or homeless emergency funds, which were being used in some places to try to plan to transition people from these hotels to permanent housing. I will end perhaps though on a more dour note. I think in some ways this pandemic has exposed what we've always known, the incredible insidious effects of structural racism, housing crowding, and homelessness on people's health. And my big fear right now is that with the massive economic disruptions, there are anticipations that we could see rises in homelessness of the scale of 40 to 50%, right at a time where our government funding is really so short, particularly for state and local governments who have to balance their budgets. So we're very, very fearful that we're going to see an enormous rise in homelessness, and a particular fear in some high-cost regions, because actually industries like tech are doing fine and there's such a hunger for housing. Our worst nightmare is that many people are going to become evicted or displaced. Housing costs aren't going to come down, and those housing is going to go to those high earning renters. So I think we need to really be vigilant for what could be enormous disruptions. That said, I think there's been some lessons learned here that hopefully we can move forward.
Yes, thank you. Thank you, all of you. You've raised really critical issues. I'm going to start with a couple of questions. And actually, my first question, I will fold in a question from the audience, because I do want to delve in a little bit more into some of these human rights issues. We as Physicians for Human Rights, as a health and human rights organization. Margaux, you co-authored an article in the New England Journal in 2016 that included the argument that permanent supportive housing should be framed as a human right. And I noticed that one of our audience members asked, it's now been lost, actually notes that some US jurisdictions, in theory, on the books, guarantee that people as a matter of right will have a place to stay. So my question to you and to the other panelists is, how do you think that the COVID-19 pandemic, if at all, has changed or will change, might change, the views of policymakers and the public on housing as a human right? You know, to start with you, Margaux, you talked about a number of very innovative approaches that are short-term approaches now, and then I'd like to also open it up to the other two panelists.
Yeah, I mean, I think we wrote that article in some ways in response to the usual framing of supportive housing because it saves money. And that's a challenging argument. It does sort of have cost offsets for the very highest need folks, but really people's humanity should not be because they save money. And when we think about healthcare, our determination of what healthcare is worth doing is not, does it save money? It's that, is it reasonably cost effective for what you get? We don't say, you know, almost nothing in healthcare saves money. And we don't say you don't get dialysis because it's not going to save money. We say it's a reasonable expense for the benefit. So we framed it that way. You know, my hope, if I'm being optimistic, is that the pandemic has made clear what those of us in this field, probably most of us in this call, have always known, which is that our humanity is shared, and that we all really, that everyone's life is of worth. And frankly, we're all in this together. And so I think, you know, when you see government scramble so much and you realize that having this nidus of infection with people who are suffering so much, frankly, not only is damaging to those people, but is damaging to all of us, you start to hear more discussions. I was thrilled this week, today, to see in the New York Times a fantastic editorial by Benjamin Applebaum about homelessness, which, other than a huge thing that he left out, which he didn't talk about structural racism, but other than that, it was just an incredible piece describing, you know, why we need to solve homelessness, why the federal government needs to do it, that we can do it. So I would like to think that this conversation has really opened up discussions of our shared humanity and of the urgency, sort of the fierce urgency of now, that this is the time we need to solve this problem once and for all.
Yes. Pascal, I think you're lighting up.
Yeah, no, I just wanted to echo that and just the importance of centering humanity in this crisis, and that these are individuals' lives and dealing with incredible trauma and stress, and but also to add that we're seeing true heroism on the part of folks on the street outreach workers and case managers approaching this incredibly stressful situation using tools like harm reduction and motivational interviewing to get at our hardest to reach and historically disconnected folks and connecting them to services. And so the good news is that we're seeing it happen and working across the country with folks, individuals who've been living in encampments for years, who've been longly disconnected from care, are getting to these alternative care sites that Margaux mentioned and are being connected and using ESG dollars, emergency solutions grant dollars, to rehouse folks. So I think, COVID has really taught us that, again, we're part of all the same social fabric, and we're only as healthy and safe as our most vulnerable neighbor. But it'll be our inability to see our interconnectedness that will lead to our collective downfall.
Yeah, I would agree with that. I mean, I think, I've been a little bit disappointed. I haven't heard housing as a human right per se stated publicly as much during this pandemic, or even health as a human right, and kind of recognizing that everybody should have an equal shot to health, and that housing is not only a human right in its own regard, but a prerequisite for having an equal shot at health. There in New York City, we have what's called a right to shelter, which was legally established, which means that people who are do need to be provided with shelter. These are homeless shelters, though, where I would hope that maybe this pandemic moves us is towards realizing that what we need is a right to housing, permanent and safe housing for everybody.
Thank you. And the second question also is a little bit folding in one of the questions from the audience, but all of you touched on this briefly, but there is indeed a tension sometimes between efforts to protect public health and human rights or civil liberties of people experiencing homelessness. How, if at all, have each of you observed this tension in your own work? And some of you have touched on this briefly, but talk a little bit more about some of these tensions.
I mean, I can start maybe by saying, I think that, there are two fears with this pandemic. One is that if we continue to highlight the incredible disproportionate risk in these marginalized populations, that it's going to increase the stigma in this. And what would be another nightmare scenario is if people are more fearful of people experiencing homelessness, or see them as, and fail to see their humanity and instead see them as sort of vectors of disease. I think a more concrete fear, and where there are a lot of discussions about it, will civil detention be used in the case of people who have COVID infection? This is something that has been used for things like multi-drug resistant tuberculosis, where health officers can require someone to be basically held against their will for treatment because of the risk of spreading the disease. There's a lot of fear that this could be used if someone, for instance, is diagnosed with COVID and does not want to come into one of these, shelter in, isolation and quarantine units. Could we start to see people held against their will? I think that in general, most places have said no, that people see the harms of doing that, and also recognize, frankly, this disease is so widespread in the community that it doesn't really make any sense. But we have definitely heard murmurings of that in certain communities where there's been discussion of whether people could be detained against their will as an effort to prevent spread. And I think that's something we need to be vigilant about.
We've seen this question play out in New York City, specifically around our subway closures. Mm-hmm. So for those not from New York City, we're known for having 24/7 subways, and historically, in an unprecedented move, our governor and mayor, as of last week, decided that they would close the subways each night between 1 a.m. and 5 a.m. The reason for closing them ostensibly is to do a deep cleaning of the subways, with the rationale that the subways need to be cleaned to protect essential workers, including the people that work for our subway system, but also everybody else that's commuting to work. But we've seen that that's come at a cost in terms of limiting freedom and limiting kind of rights for another group of people. So in New York, we have on average, like on a given night, the most recent count was that there are around 2,000 people here that sleep on the subways. And so with these nightly shutdowns of the subways, those people have been forced to leave from where they've been sleeping. We do have outreach teams at 29 of our subway stations, but there are about 500 subway stations in the New York system. And so in a lot of places, people are just being asked to leave and out, into the cold and it has actually in New York been unseasonably cold last week. Thankfully, it seems like it's starting to get a little bit warmer. And then we've seen other people, put into minivans, put into buses and taken to congregate shelters. And unfortunately, in some cases, into situations where there's not a bed for them. There were pictures that came out in the news just yesterday of people who had been taken from the subways to shelters, kind of sleeping lined up on the floor, not socially distanced. And so we have seen this situation where, it's reasonable to want to clean the subways and protect essential workers, but we've seen that the consequence of that has been creating what could be potentially dangerous situations for another group of people, and certainly limiting that other group of people's freedom to sleep where they had chosen to sleep.
Anything else, Pascal? Anything on this question? Okay, yeah, so I actually, this is a link to another human rights issue, a question from the audience. Thinking about, the issue of mass incarceration and decarceration, and really decarceration and its relationship with the homelessness issue in the setting of COVID-19. A key issue that Physicians for Human Rights and other rights organizations have been really, really pushing for is the need to release people from prison and from jails that can be released, as well as from the ICE detention centers. And most of the people in ICE detention centers have families that they can return to and shelter in place. But I think we haven't talked about this in this panel, but we all are aware of the really inadequate support that's given to people when they are released from prisons and jails. And to talk a little bit about how this is playing out in COVID-19 and what you're seeing around this really another massive issue that is contributing to homelessness in this country. I don't know.
Pascal, you're muted. Pascal, yeah.
Pascal, please. Oh yeah, this is such a gap.
So I'm happy to start. And so I think we're witnessing places like jails and prisons and nursing homes are really where we've seen the biggest spread. And I think in Ohio, we've seen that their prison, one of their prisons there has actually the highest per capita number of COVID positive cases, right? And so not only is this in danger for those who are detained, but also for the staff there as well. And the challenges that we're seeing, that there's about a handful of states that are doing compassionate release, looking at folks who are low-level nonviolent offenders, those who are over the age of 50, which also brings another concern. I know that Margaux and Kelly probably know well that the accelerated aging that happens in prisons and settings, actually you age faster than you would on the street or in shelter. And so thinking about the care needs and the care coordination and the lack thereof that we're seeing as folks are being released from jails and prisons. And also not knowing their testing status. Are they testing to see if folks are COVID positive, or finding out what communities are they going to? A lot of folks are returning to communities that are already densely populated, to homes that are already overcrowded, putting themselves and family members at risk. And the folks who are already under-resourced. And so if we're not tracking that, and as we see all these dollars flowing from the federal government, how are we getting the resources to the folks who need it most? And then knowing that our jails and prisons, and for example, Rikers is the biggest psychiatric care facility in New York, what's happening to the continuity of care and services that folks need when they're re-entering the community? And so those are a number of more questions and concerns than we're hearing about the coordination that's happening.
Absolutely. And I think we see this sort of human rights catch-22. I mean, it's been really gratifying to see this recognition of decarceration as just so crucially important, and and we're seeing it happen in real time in certainly in California, both in San Francisco, decarcerated a tremendous proportion of our jails, and it is working on decarcerating as well our state prison system. But in some places, having a place to go home to is a requirement to be decarcerated. And on one hand, that makes sense, I guess. But on the other hand, it's actually really horrifying to think that someone could be essentially, then we are admitting that we are keeping people in carceral systems because we haven't provided housing. I think, there have been some efforts in some places to provide some of these type of shelter-in-place hotels for people, earmarked for people leaving, being decarcerated. But again, I think just another human, it sort of shows how broken our system is, that we are effectively admitting that we are keeping people in carceral systems for lack of our housing system.
Kind of linked to this question of congregate settings, we have a question from the audience from someone who's a director of a seasonal emergency shelter. And what he writes is that they are leasing the shelter space from a church, and they were told that the lease will not be renewed for the summer because they're concerned about the spread of COVID-19 in the shelter. And they had already had their lease terminated in March due to similar concerns. And so this does raise what the director is asking is given the option of having a congregate shelter or no shelter at all, is there a clear right decision about whether they should push to try to have a shelter? So that is, so talk a little bit about that. I know, again, Margaux, you spoke about different solutions, the housing in hotels and other solutions, but do we want to argue that we really should have no congregate shelters, or what's the approach to thinking about congregate shelters? Yes, Kelly, I can see you.
The CDC has actually put out guidance on this, and it's fairly clear on their website. So, that might be helpful to the person who asked the question and to the landlord to see. But, despite what I spoke about, what some others spoke about with the dangers of congregate shelters, there's still necessary human resources for people, and the CDC recommends that they are not closed because of the pandemic, and that they don't, start closing their doors or turning people away. I think it would be, it's a hard situation, right? There's so much fear about COVID. And so I think trying to understand a little bit more about what the landlord's fear is in particular might be useful here.
So we have just a couple more minutes. So I do want to really focus the three of you on the future. Some people have argued, and I think some of you have argued just today, that this crisis may present opportunities to rethink homelessness and to make strides perhaps on ending homelessness moving forward, and to rethink how we do support and think and help those who are facing homelessness. So I'd love for each of you to reflect a little bit on why shouldn't we yearn for a return back to normal. What has COVID taught us? What are new opportunities? And this includes new opportunities to build strong health and housing partnerships that I know all of you are working on. It's 2:49. I think we should wrap up just a couple minutes before 3. So go crazy. Give your vision. What would a new normal look like? And again, Margaux, you touched on this because you were assigned the future part of the panel, but talk a little bit about that. What have we learned? Pascal, why don't you start?
Yeah, I'm happy to go first. And so I think today's crisis really presents an historic opportunity to really transform how we routinely address the homeless crisis. Put simply, housing with the right level of supports ends homelessness. And so I think it's a reckoning and a wake-up call for America. And then also that we can't effectively manage public health without addressing homelessness. And so we've been saying that housing is a human right, and that housing is public health. And I think this is really underscored that. And I think it's also not the time that to be short-sighted in our response, but then use this as a catalyst for real transformative change. And so one thing that we are doing in understanding the need of supportive housing, the 1.1 million Americans that we've identified through our own research, and this cuts across not only homeless, those who are in institutional settings like jails and prisons, child welfare, and nursing homes, but that we need to fight against the usual kind of siloed approaches to care that really has stymied opportunities to address the whole person and their needs. Instead of having folks run that gauntlet from shelter to emergency room to child welfare to the unemployment, the food pantry, and so on. And so, you know, I think we have a great foundation to build off of. We've been seeing strong health and housing partnerships, whether it be health centers working collaboratively with supportive housing providers, hospital systems actually investing. I think Margaux touched upon this, not only in medical respite, but actually in the development of housing, of supportive housing, and seeing themselves as anchor institutions and their role in public health outside of the walls, the clinical walls of their institutions. And so we have a foundation. I think it's time for bold and strong ideas, and you know, we're ready for it.
You know, I think the reason why we shouldn't yearn for the old is that old was wrapped up in a system that is really baked into the racism and structures that built a deeply inequitable society, and we are seeing the fault lines of that in a really profound way with this pandemic. I think we need to also realize homelessness is entirely a human-made problem. We created it. We can fix it. And, you know, it's really interesting. We always seem to like blame mayors for it, and mayors have actually the least that they can do to fix it. And then we sort of sometimes blame governors, and they have a little more they can do, but not that much. And we completely let our federal government off the hook. I want to remind everyone that the federal government deeply, deeply subsidizes home ownership. Because of these de jure policies that were written into the law, Black Americans, Indigenous Americans were effectively left out of that. In what normal sort of thinking world would you subsidize my housing and not subsidize the housing of my patients? We currently spend $12 billion a year on homeless shelters. I think that the pandemic has made clear what a disaster homeless shelters are. And frankly, about half the population isn't even in shelters. It would cost an estimated $41 billion more than we're currently spending on vouchers to provide a housing voucher for everybody who meets criteria. Right now, only 1 in 4 households who meet criteria get it. It is not an entitlement. That may sound like a lot of money, but it's actually, as Benjamin Applebaum said, that's a rounding error for the federal government. We could do that. The market probably can't solve this. We also need to deeply subsidize the development of affordable housing. Again, that is not a huge cost for the federal government. We just simply have decided to not do this. This problem is entirely human-made. It has nothing to do with individual vulnerabilities. It has everything to do with our federal policies. There's an act now being debated in Congress as we speak, the HEROES Act, which is another subsidy which has a lot of money written into it for rental subsidies. We need to be pushing for that. We need to be pushing for a return to subsidizing the development of affordable housing, subsidizing people's rental expenses, and we need to center racial equity in each and everything that we do. Are we going to get there? It depends whether you're an optimist or a pessimist, but what I always like to say is if we don't think we're going to get there and we don't try to get there, we're certainly never going to get there. This is totally doable. We just need to do it.
Wonderful. Kelly.
I almost don't want to, I almost want to end with that message, but you know, I think that this pandemic has just highlighted more than ever just the interconnectedness of all of these systems. As far as the healthcare system and the homeless services system, and we've really seen in the hospitals that it's impossible to truly address people's health when they're homeless, and to be able to ensure health from them. We've seen that the systems are sometimes fragmented and that they need to work better together. But I think more than anything, we've just seen that this is all really needs to be about ending homelessness, and that it's just, you know, not okay that we have over 500,000 people who are homeless in the United States, and that we need to move away from some of these congregate shelter type solutions and towards housing and other long-term solutions that recognize people's choice and people's dignity and people's humanity. And, you know, like the other said, these aren't easy problems, but they are solvable problems. And I think that the pandemic has shown people in homeless services sectors, in the healthcare sector, kind of, you know, everybody, that they are capable of doing things they didn't think were capable. I mean, New York City, you know, despite some problems in what it's been doing, has moved thousands of people into hotels and to protect them, and nobody would have thought that that was possible before. And so, you know, how do we just move from this moment to create something that's better for everybody and that does not, you know, result in 500,000 people without homes in the United States?
Thank you. Thank you, all of you. Well, all of you, or each of you and all of you are working to make that vision possible. And I thank you all so much. I think you've also given us all, the medical professionals, the policymakers, the legal people, the advocates, you've also given us some really good thoughts for ways that we also can help push for that vision. And I'm gonna turn it to Donna for concluding comments. Thanks, all of you.
Michele, thank you so much for this remarkable panel. It was so inspiring and filled with really fantastic information. You know, COVID-19 may shine a bright light on just how broken our system is and the hideous effects of structural racism, but these champions, you, along with so many others who joined us on the Zoom today, are looking at opportunities to rethink homelessness and how we support those facing homelessness. I like the not with a yearning for a return to normal, but as Pascali said, this is a reckoning and a wake-up call, and a real historic opportunity for how we address homelessness differently. I think so much about this COVID pandemic is a crisitunity. I may have made that word up, but it really is, and I just so appreciate how this group of advocates is looking for every opportunity here to turn the tide and helping us to see how this is doable. So many of the people on today's call are policymakers and advocates who are bringing their everything to this issue. So thank you to the panelists, Michele, for your great moderation and bringing us all together, and thank everyone on the Zoom call. I just want to let everyone know that we have a weekly webinar, and next week, next Thursday at noon Eastern time, we'll be talking about the importance of balancing public health and safety with economic reopening. So I hope you'll sign up for that webinar and visit us at our website. There are things that can be done, and there are actions that you'll find at PHR. So thank you so very, very much, and keep on doing the amazing work you're doing.
Thank you all.